whatever measurements on a ceph, lateral ceph, the ceph is lateral ceph, and whatever measurements you take on a lateral ceph is cephalometrics. Okay. Now a few things about these things. So Broadbent was a guy. Broadbent was the guy who discovered cephalostat. Now it was a very, very big discovery because cephalostat enabled holding of the head in one place. So when the head is held into one place and this distance was oh, I'm so sorry. No, I am sharing screen. Rupika, could you just see if there is something wrong at your end? I am sharing the screen. Yeah. So Broadbent was the guy who discovered cephalostat. Cephalostat is cephalo means head. Stat means stable. So this this thing stabilized the head. Now, stabilizing the head is very important to see what happens from one time to another time. Okay, so this distance has to be constant. So what is it? It is 60 inches, 15 centimeter. These distances you have to learn. These distances you have to learn. It is given variable in two different books. So just remember them and try to find out which question will have been answered in the exam. Now we will see what all points are there. So when how do we draw? We just put a ceph sheet in front of it and we take an illumination board. We put the ceph on the illumination board with the sheet on the top of it. We paste the sheet by a sellotape, and then we start marking the points. Not actually marking the points. First we draw it. Like we will draw like this. This is the nasal bone, and then we draw this. And at the back, we'll draw this like this. This is the base of the mandible. This is Fella Trashica. Okay. Now, for the mandible, if you have to draw, it will be like this. So this is how you draw. There are two lines. So first you draw first line, then you draw the second line, and you take a middle line with a dotted portion. Okay. So these is how we draw the whole of the ceph. Now the points that you need to remember. So where this line, this is nasal. This is nasal, this is nasal bone, and when it contacts with the anterior part of the skull, it is nasia. The next is when you draw these two lines. Okay, after that you draw a middle line, dotted one, and the base of this line, this is orbital. Okay, then you draw the palate. This is the palate. Okay, and just going like that. So the tip of this palate. Why draw middle lines? Because these are bilateral structures. Okay, these are bilateral structures. So if you see, this is a 1 point and this is another point. So we have to take an average of these. You have to take an average of these two for all the bilateral structures. So whatever bilateral structures you see, you take an average of that, except for the molars. For teeth, we just take 1. But for all the bilateral structures, you take a middle line. You draw 1, then you draw second, and then you draw a middle. You can draw a middle. Being very smart, you can draw a middle line, but your seniors would not let you do it. And when you grow up, like you won't draw 2 lines. But this is how you draw it. In exam, this is like this. You draw two solid lines, and then you make a middle dotted line, which is the thing that you have to take into consideration. Okay, so the lowest, I'm not going to tell you the definition. I'm just going to tell you how the point looks like. You can collaborate with the definition, but then you can correlate it with the definition. So this is orbital. The tip of the maxilla is anterior nasal spine, A and S. Anterior nasal spine. Then after the anterior nasal spine, you draw the anterior border of the mandible, which is visible. And the deepest point here is called point A. Point A. Deepest point. This is the deepest point. Point A. This is also called subspinal. Point is also called subspinal. Why subspinal? Anterior nasal spine ke niche. Sub is below. So below the spine is subspinal. Okay. So point A is called subspinal because it lies below the ANS. Okay. So we have drawn this. It should be like this actually. So this is the deepest point A. Then the point of the bone and this is the central incisor. So the point at the junction of these points. This is called prostheon. Prostheon. Now this prostheon is also called supradental. Supradental. Now why it is called supradental? Because supra means above. So supra eruption ho jata hai, something above. So supradental because this is above the dental related to teeth. So above the teeth is called supradental, which is point prostheon. So prostheon, you understand? Prostheon is just above the tooth. So prostheon is also called supradental. Next is the lower border, lower jaw. Lower jaw, this is the symphysis region. So this is how you draw it, like this, and then you take the lower incisor. Now we have this point at the junction. Now this is called prostheon. This is called inferior prostheon. Okay, this is below inferior prostheon. Now this is below the tooth. So this is called infradental. Infradental. Why? Because this is below the tooth, below the lower incisor. This is called infradental. Now point B is the deepest point, which is point B. So point B is the deepest point here on the anterior surface. Then this is the most point B. Point B. Point B is also called supramental. ठीक है, supramental क्योंकि वो मेंटन के ऊपर होता है. ठीक है, मेंटन के ऊपर होता है. This is what? This is menton. This is a constructed point. This is pogonium. So this is deepest. This is most. How do we draw this? Actually, we take a reference line. We take reference line as. Where is that one? I have not drawn that line. So we draw this line. This is FH, and iske parallel we see. This is the deepest point. Just parallel to this, sorry, perpendicular to this. This is the most anterior point, pogonium. Now, when you connect these 2 points, so when you connect these 2 points and you draw a perpendicular bisector, it will join somewhere. So this point is called gnathion. Where did we read gnathion? हमने पहले भी पढ़ा है gnathion somewhere. Anyone? Where have we read gnathion? Anyone? Do you remember anyone? Facial index. Yes, you need to remember that. So facial index from this ho gaya. Now this point. What is this point? This point is gonion. How do we draw it? We take the posterior base line and the base of the mandible line, and then we bisect it. So wherever it falls, that is gonion. Okay, anterior mein this was ANS, anterior nasal spine. This posterior point is PNS, posterior nasal spine. Okay, next point we'll discuss. Now when we draw the mandible, this is the mandibular condyle, and this is the base. Now these 2 points, whenever they intersect, this is called articular. Okay, this point is called articular. Then we draw the inferior auditory meatus. The highest point on the cavity of inferior auditory meatus is called porion. Porion. So when you connect porion and orbital, this is called FH plane. Now what is this point? This is the center of Sella tertica. So we draw sella tertica and the center of this is sella tertica. I think porion is not this. I think this is not porion. So that is the problem, Kina. It is not really that clearly visible. I think inferior auditometrics is here. Okay, let's go back a few slides. So if you draw the mandible like this. Now I'm drawing like this because I'm not able to see it very clearly in this. This is why we draw it on an illusion board. Okay, so this is the highest point on the condyle basically. Yahan pe inferior auditory meters. Can you see this? This should be an inferior auditory meters. And the top of this is porion. Now top of this condyle is condylium. So this is what happens whenever you draw on lateral cephalon. Now, how do we draw articulate? We draw the condyle, and wherever it intersects this line, this is the base of mandible. Sorry, base of the skull, and this line continues like this. So this point is called articulate. What is this? This tip is called bayesian. B-A-S-I-O-N. Bayesian. Okay, now only one point is left out of all of these, this point. Okay. Now, this point is called PT point. PT point. You need to understand how I draw it. How do you draw this PT point? So, I'll take another color. So, you draw these two lines. This is one. And this is another. Okay, ये दोनों draw किए. उसके बाद you draw an average on these. I'm drawing it an average just to make it more clear to you guys. Okay, when you draw an average and then you find out a 10 o'clock position. So 10 o'clock position is PT point. Yeah, you can have a picture of all these points marked, but it is very important for you to understand how these points come in, because some points are not really right. Okay, I'll tell you why. See, this is ANS here. ANS is not this front. This is the cartilage of nose. Okay, PNS point is this. It is not here. Again, this is the internal auditory meatus, and they have set this point to be porion. So this diagram is not correctly written. This is why I'm explaining these points. This red point is given wrong in this diagram. So this is why I'm trying to explain it to you how these points are drawn, so that whenever question is asked, you know how it is drawn, so it would be much easier for you to answer the points. Even if you forget the language, even if you forget the exact definition of a point, then also you'll be able to attempt the question. Okay, this is why I'm trying to explain how these points are drawn. Okay. So I think I've covered all the points here. Now I'll move on to another point. Now this is a diagram of a full skull. So if you see the posterior base ends here. Now this point is called opus. Okay. Anterior point, we have discussed what is this called. This is called bayesian. So I'll just read out the definition of opistheon. Opistheon is the posterior edge of foramen magnum. Now this is foramen magnum, the posterior edge of foramen magnum. Okay, it is the most posterior point on the posterior margin of foramen magnum. So just to understand this point, it would be very easy. The posterior most point on the posterior margin of the porion. Okay, porion is, I'll just tell you. You draw the inferior auditory meatus, and the top of the inferior auditory meatus is porion. Okay, the top of the inferior auditory meatus is porion. When you draw it like this, and tip of this is bayesian. Okay, and when you see a complete, now this is bayesian. External auditory meatus would be somewhere here in this patient. Now another point, last point. Last point, we know bayesian. This is bayesian. This is bayesian. This is opisthion. Now this, between these two, bayesian and opisthion, is the Bolton's point. What is the definition of Bolton's point? Highest point on concavity behind occipital condyle. Highest concavity behind occipital condyle is Bolton's point. Bayesian point ka definition is, it is the most posterior and inferior point on the anterior body of foramen magnum. So anterior body is, and this is foramen magnum. Okay, this is foramen magnum. So anterior most point is bayesian and posterior most point is opisthion. Okay, so you read the definition, go back again, read the definitions and try to correlate with the actual points, because in exam you might forget the definitions. So you need to remember the points. Now what is PTM point? PTM is the lowest point of this pterygo axillary PTM point. Okay, PT point was here, PT point. So you need to remember all these points. These are very important because every time at least one question is asked from these points. Now you need to remember a few points from the Ricketts analysis points. I'm going to tell you 2-3 points from this, how to make rest of the points you remember. Xi point, I'll tell you how to remember. RR, you remember it. That Ramus reference point is from Ricketts analysis. Eva point, Eva was Ricketts' mother. Murray was Ricketts' father. So he named 2 points on his mother and father. So Eva point, Murray's point, root radius, center of cranium, sector of condyle, and pterygoid point, PT point. So PT point kaise banate the? You take the pterygomaxillary fissure, then you draw these 2 lines, and at the intersection, at the 10 o'clock position is PT point. Okay. Now I'll tell you few other points. First is Xi point. How to draw Xi point? I'll just explain it to you. So when you draw the mandible border, you draw the mandible. This is the mandible. You draw the mandible on a lateral set like this. You take mandible. Just not that clear in this. It's like this. So you draw the outlines of the mandible. These are the outlines of mandible. Then you draw the FH plane. So you have drawn the FH plane, you have drawn the outside of the mandible. Now, parallel to this plane, the deepest point on this notch is R3 point. It is written. Now, corresponding to this deepest point on the lower border of mandible is R4 point. Okay. Now, the deepest point on the anterior border of the ramus is R1 point. Corresponding to this is R2 points. Now you have got 4 points. You make lines on those points. After making these lines, you draw the diagonals. And wherever they intersect, this is Xi point. Okay. So you need to understand how this is point. You take the deepest point on the first concavity, corresponding point R4, deepest point on the anterior border, corresponding point R2, you draw it as a square and you diagonally cross it. This is Xi point. Xi point has been asked in exam, so you need to remember it. Next point is Eva point. Eva point is actually visible. There are lines like this, and this is the Eva point. It is called as medial confluence. Confluence means when they meet, meeting point. Confluence is the meeting point of stress lines. Something is wrong with my digital pen today. It is giving these little strokes. So medial confluence of the stress lines on the medial surface of ramus. So when you watch the ramus from inside, there are thickening in the bone of mandible like this. And this point is called Eva point. it was named on Ricketts' mother. Okay, so you have understood the EVA point. Then is the PM point. Okay, how is PM point made? You draw the anterior surface of mandible, and wherever there is the confluence between the convex and the concave surfaces, there is PM point. Okay, so PM point you know, EVA point you know. Now I'll tell you how do you draw the true radius. You take a divider. This is a divider, and you place it on PM and EVA. You got this length. Now you place 1 point on PM and you draw this line. Okay. Now you take 1 point on EVA and you draw this line. And where these two meet, that is called TR point, which is called true radius. Okay. Now you take the same measurement and you place your divider here and you draw an arc. So the arc will cross point PM and point EVA. Now when these arc cross point PM and point EVA, this arc which is made represents the growth of mandible. This is the arc which represents the growth of mandible, and this is why it is called archeal growth of mandible. Okay, I think this is it. This is too much for you. Not even a postgraduate would understand all these points. Okay. I'll explain 2 more points again. Okay, first you take the list of the points because this list is very important. List of important points of Ricketts analysis. You just remember that these are from Ricketts analysis. Now I'll explain you jaldi se how xi point is created. See, we have a lot to cover, so let's do jaldi. So first you make the first you draw the line of mandible. This is how you draw the line of mandible. Then you take FH plane. Okay. Then just parallel to this, the deepest point on this concavity is R3 point. Okay. Now place your scale on this and the corresponding point on R4 on the lower border of mandible. Again, the deepest point on the anterior border of ramus is R1 and the corresponding point is R2. Now you have got 4 things. You draw the lines R1, R2, R3, R4. You will get a square. Sorry, rectangle. Now you diagonally dissect like this. Okay, now this point of the intersection is called xi point. Okay. Now we'll not go into the details of xi point. Xi point is very important. Next, how do you draw EVA point? EVA point is visible as the confluence of medial stress lines on the mesial surface of mandible. When you see a mesial surface of mandible, these are actually visible on the mandible, and you just draw the point. Okay. Then how do you draw PM point? Whenever you are drawing this type of S, whenever you draw an S, so there is a point when this kind of curvature meets this kind of curvature. So this point, this very point, like here, if you're drawing this point, then there is a point when this curvature meets this curvature. This point is called PM point. PM. Okay. This is called protuberance menti. Protuberance menti. PM. Okay, PM point. Now take distance of PM point and EVA point. Put your divider on PM point and draw an arc. It would be like this. Put your divider on EVA point. It will be like this. and wherever they meet, it would be true radius. Now put your divider on TR and draw an arc. This is the arc. Like, I cannot draw it with a free hand. Now this is the arc which represents, around which the growth of mandible occurs. This is why mandible occurs. This is why it is also called archeal growth of mandible. Okay, I hope I've done justice to this, and I hope you all understood it. Now let's see a few soft tissue points. Now, first thing that you remember about soft tissue points is soft tissue shield. When you place a soft tissue shield, then soft tissue points are more visible because it avoids extra exposure of these soft tissue points. Now, the same points we see for soft tissue, and we call it soft tissue. G is glabella, P is pronasal. P point has been asked in exam, so special emphasis to this. Pronasal. Okay. COL is columella. Columella. SN is subnasal. Nose के नीचे subnasal. Then A dash is soft tissue A point. ULA is upper lip anterior point. Stomion superioris, stomion inferioris. Now stomion has been asked in exam. Stomion is mouth. So stomion superioris on the upper lip and stomion inferioris on the lower lip. Okay, these are the main points to remember. Now the next thing that you need to remember are the planes. What all plane do we draw in cephalometry? So the first plane is SN plane, joining the point sella and joining the point nasion. SN plane. Now SN plane was used in Steiner's analysis. Next is porion, the uppermost point on the concavity of the inferior auditomus is porion, and the lowermost point is orbital. When you join porion and orbital, it is FH plane. It was used in Down's analysis, and it is used in a lot of analysis. Then when you draw the line, now this occlusal plane is drawn between the plane where all the teeth are occluding. So that is occlusal plane. Then is gonion to menton, mandibular plane. Okay. How is facial plane drawn? Facial plane drawn nasion to pogonion. Nasion to pogonion is facial plane. Next is y-axis. How do we draw it? Sella to nathion. How do you draw nathion? Nathion you draw pogonion and mental and you bisect it. So nathion. So when you connect sella and nathion, that is y-axis. These planes are very important. You need to remember them. The other thing about planes is the degrees between them. So the angle between SN plane and FH plane is 7 degrees, 6 to 7 degrees. How do you remember that? This is the third time this figure has come, 6 to 7 degrees. 6 to 7 degrees is neural, it was mentioned in that this diagram. What was it? Scammons growth curve. Okay. The next, you need to remember the degree between FH plane and the occlusal plane. What is the degree between this? This is 10 degrees. So these two degrees are very important. The degree between SN plane and FH plane is 6 to 7 degrees, and the degrees between FH plane and the occlusal plane is usually 10. Not for all patients. Not for all patients, but usually 10. Okay. Next, I'll explain what all mandibular planes are used. In the last slide, the mandibular plane was gonion to menton. Now, there are 3 types of mandibular planes. Okay. So, first was down. Down's mandibular plane is gonion to menton. So, GO to menton. The lowermost point is menton. Okay. Then tweeds was tangent to the lower border of mandible. So this one is tweeds. Okay, the menton one is downs. And the last is Steiners. Steiners is gonion to gnathion. So Steiners is this. Okay, so you need to remember all three mandibular planes because every analysis uses a different mandibular plane, so you need to remember. So how do you remember which is which? Down means the lowermost point. So going on to write down T for tweets, T for tangent. And Steiners is the last one. Going on to gnathion. Okay. Now next we are going to discuss Down's analysis. What points he considered in Down's analysis, what are the degrees to it, and what happens if there are changes in the face of whatever he says. So the first angle in Down's analysis is facial angle. Okay, do you guys need a break? If I get 5 yes, I'll give you a break. I need 5 yes. Do you guys need a break? So I've got 3 yes, 4 yes. There are more no's. Okay, so we'll not take a break. There are no no's. Okay, let's take a 2-minute break. Just okay, let's take a 3-minute break. Just sit down, close your eyes, and try to relax. And we come back in 2 minutes. Okay, 3 minutes. We come back in 3 minutes. Okay, we start again. Now, what is G? G is glabella. Okay, now we're going to discuss Down's analysis. So Down's analysis. So he gave some points, he gave some things. So we are going to see every point one by one, and we are going to see what happens if it increases, if the point increases or decreases. So first is facial angle. So how the facial angle is made? It is the angle between the end pog, N is gnathion, P is pogonium, and between the FH. Okay, it is this angle. This angle is facial plane. Point between angle between nasion and pogonium and FH. This is this angle. So the average value is 87.8 degrees. What will happen if this value increases? Okay, how will this value increase? If the pogonium point, comes forward, if it comes here, so the angle would be like, the angle would be like this, and this will lead to increase. So if it increases, what will happen? It will lead to class 3. In class 3 patients, it increases. What if it decreases? It decreases in class 2. So in class 2 patients, we have a decreased value of facial angle. Okay. The next point is angle of convexity. Something is still late on. So The angle of convexity is nasion to point A and point A to Pogonium. Ideally, all these 3 points should lie in a straight line and the angle should be 0 degrees. Ideally, all these 3 points should lie in a straight line and the angle should be 0 degrees. If they don't lie in a straight line and this point is, say, forward, so there will be some angle. When the point A is forward, it has prominent maxilla. And if point B is forward, then it is prominent mandible. So that is class 3. Okay. The next angle is AB plane angle. I'm going really slow. Okay. So the next angle is AB plane angle. So AB plane angle. Now, AB plane angle is a point joining A and B. Yeah, this point joining A and B and NPOG. NPOG is the facial plane. So the point between joining A and B and facial plane, this angle. Okay. Now this is 4.6 degrees. Now it is because in the backward direction it is called minus 4.6 degrees. What happens if this angle increases? Now, if this mandible comes forward, this line, if mandible comes forward, B will be somewhere here and A would be like this. So this angle would be minus 1 degree, say for example. So if this angle increases, minus 1 is larger than minus 4.6. So if this angle increases, it is in class 3 patients. If it decreases, it is a class 2 patient. Okay. Now, if it increases means the Pogonium point will come forward. So the angle will become negative में less. Sorry, negative में more. Now, the next angle is mandibular plane angle. The angle between the mandibular plane. So mandibular plane, what is the mandibular plane? It is gonion to menton. I don't know. This is not very good. Gonion to menton would be somewhere here. Ideally, थोड़ी सी ऊपर होनी चाहिए line. So mandibular plane and the FH. No, actually, it is not here. It is not shown. The angle between the mandibular plane and FH. This angle. How do you measure this angle? You transfer this line here. You transfer this line here by set squares and you measure this angle. Now this angle is 21.9 degree. Mandibular plane angle is 21.9 degrees. What will happen if it increases? If it increases means the Pogonium will be way down, sorry, menton will be way down like this. So this is an downward rotation. So it would be a downward rotation or a hyperdivergent case. Hyperdivergent are downward rotators and forward rotators are hypodivergent cases. These are two different terms for the same concept. Forward rotators and backward rotators. The forward rotators are hypodivergent. This is forward rotation of mandible. Somebody asked me, why do we study rotations? So we study rotations because it is important in the clinical treatment of the patient. Okay, the next axis is y-axis. Okay, so do you remember the y-axis was sella to Nathion? This is not Pogonium, sella to Nathion and FH. It is this angle. So this angle is basically 59 degrees. Y-axis is 59 degrees. What happens if it increases? It will increase, matlab, Pogonium is, Nathion is somewhere here. So it increases in backward rotators or forward rotators? Anyone? Y-axis increases in backward rotators or forward rotators? Anyone? Backward rotators, yes. So it would be a hyperdivergent patient. In hyperdivergent case, y-axis will increase. Okay. I'm so glad I'm able to make you understand. Down's analysis also had some, what do I say, some dental points. Now this is very good, very good, everyone. Now this is the this was the skeletal points. Now dental points were also there. So what are the dental points? Yeah. So dental points is first is cant of occlusion. Cant of occlusion means the, sorry, it is not like cant. It is like this. So sorry. Cant of occlusion. Sorry, occlusion. SIUN. Sorry. Cant of occlusion. So occlusal plane and the FH plane. The angle between occlusal plane and FH plane. In this diagram, it appears to be very large, but it is actually 9.3 degrees, not even 10. 9.3 degrees. So the anterior occlusal plane is directing it to downwards direction, and the angle is 10 degrees. Next is the interincisal angle. Interincisal angle is at the long axis of central incisor, upper central incisor, and the long axis of the lower central incisor. This angle. So this angle is averagely 135.5 degrees. These degrees will be mentioned in book. I'm just here to explain. So in which case the interincisal angle is, agar ye aur bhadega, to in which case it will become larger it will become larger like this. This is a larger angle. So it will become larger in cases of, not retrusion, not open wide. It will become, no. This angle is between the long axis of teeth only. So we have to talk about proclination or retroclination of teeth. So it increases in retroclination of teeth. When the teeth are retroclined, say for example, in class 2 div 2 case, it will increase in class 2 div 2 case. Yes, it will increase in retroclination of incisors. And when the incisors are more proclined, this angle is going to decrease. So in cases of bimaxillary protrusion, proclination or protrusion, this angle is going to decrease. Okay, in cases of proclined incisors, this angle is going to decrease. Okay. Now is incisor occlusal plane angle. When you draw this long axis of lower incisor and the mandibular plane angle. Okay. Now this smaller angle, not the larger one, the smaller angle. This angle is usually 14.5 degrees. This angle is 14.5 degrees. In which this angle is going to increase. Now, when this angle increases, this is incisor occlusal plane angle. Okay. So, in the cases of lower incisor proclination, this angle is going to decrease. Yes, very good. Now, the last angle is upper incisor to apoc. So, upper incisor like the angulation of the upper incisor and point A and pogonium. Apoc. So, no, actually, this is a mm measurement. This is not an angular measurement. This is an mm measurement. Means you draw a line apoc and then you measure the distance like this. So this distance is actually 2.7 mm. When this distance increases, it means that there is proclination of incisors. And when this distance decreases, there is retroclination of incisors. Okay, so you need to remember these points, and you need to remember what happens if the angle is increased or decreased. Next analysis we're going to discuss is Steiner's analysis. Last angle is it is last measurement is apoc to upper incisors, which is an measurement. It is not an angle. Okay. Next is Steiner's analysis. Y-axis is called the growth axis. Dr. Ria Hazarika. Y-axis is the growth axis. Next is the Steiner analysis, in which first is angle is SNA. So you take S N, you take S N and A. So this angle is 82 degrees. Then is SNB, SNB. So this SNB angle is 80 degrees, SNA is 82 degrees, then is ANB, 82 minus 80, 2 degrees. Then is mandibular plane angle. What is mandibular plane angle? The angle between SN and mandibular plane. Okay, so this angle between these two is basically 14 degrees, in which when the angle increases, it would be a hyperdivergent patient, matlab a backward rotator. Then is the occlusal plane, between the occlusal plane and the SN. So this angle is basically 32 degrees. Okay. Then Steiner also gave some dental measurements. So what were the dental measurement? Dental measurement was upper incisor to NA in degree and in mm. So how much degree is that? Upper incisor to NA means point N and point A, you draw a line and the long axis. So the degree is 22 degrees and mm is 4 mm. Degree and linear, yes. Degree and linear. Then is lower incisor to NB. Again, degree and in mm. Degree and linear. So degrees were 25 degrees, linear was 4 mm. Not 44, it is 4 mm. Okay, and the last angle was interincisal angle. Interincisal angle decreases in proclination of incisors, which is 130 degrees. So this was very easy. Steiner analysis. Easy, good analysis. Next is Steiner also gave a line, which is called S line. Okay, how do you draw S line? You take Pagonian, soft tissue Pagonian. You take soft tissue Pagonian and you take an S like this. Excuse me. And the same way, when the concavity and convexity meet, जैसे हम PM point में करते हैं ना, when the mandible convexity meets the concavity, the center of that point, likewise the center of the lower curvature of the nose, you take that point and you draw a line from Pagonian. This is S line. Sorry for this. So you take the center of this curvature. You take center of this curvature and you take point Pagonian and you draw a line. This is called S line. So what is the relevance? The upper lip and lower lip. Both these lips should touch the S line. Okay. So upper lip and lower lip, both these should touch the S line. Next analysis that we are going to do is Tweed's analysis. Tweed's analysis. Now in Tweed's analysis, this somebody has asked this question also. So Tweed's analysis, we take three things. First is first thing is we take the lower incisor ka center of the lower incisor. Then we take the Tweed's mandibular plane, the tangent to the lower border of incisor, lower border of mandible, and we take the FH plane. Okay, so we have got a triangle. This angle at the back is called FMA, Frankfurt mandibular angle. Frankfurt mandibular plane angle also. The value of this angle is 25 degrees. This angle is IMPA, incisor mandibular plane angle. The value of this angle is usually 90 degrees. And the rest remaining will be 65 degrees. So there was a question which is a hyperdivergent and a hyperdivergent pattern. So what if this angle increases? Angle increase over, so what will happen? Will it be a hyperdivergent or a hypodivergent? Anyone? It's a hyperdivergent. So whenever FMA is larger than 25 degrees, it's a hyperdivergent growth pattern. And whenever, so accordingly, if this, now one more question. If FMA, this is all usually 90 degrees. If FMA is 35 degrees and this is 90 degrees, what will be this angle? How much will be this angle? This will be 55 degrees. Now the question can also be asked like this. If FMIA is 55 degrees and incisor IAP is 90 degrees, what kind of divergence would be there? Okay, so you don't confuse yourself within that and you try to answer the question accordingly. Okay. Next analysis that we're going to see is width appraisal. Width appraisal. Width appraisal, what it says, it takes a FMI is Frankfurt mandibular plane and incisor angle. FMI is Frankfurt mandibular plane and incisor angle, between incisor. Frankfurt mandibular incisor angle. Okay. Now the next we are going to discuss is width appraisal. In width appraisal, we'll draw an occlusion line, occlusal plane, and we take a drop of point A and point B. Okay, it is usually 0 degrees in females and -1 degree in males. Okay, so this is 0 degree in females and -1 degree in males. Remind me, I'll just recheck these values and I'll come again. Okay. Next is APTI. Please try to understand this APTI. This was asked in, yeah, it is a linear value. Dr. Manisha, width appraisal is a linear value. So what we do, we just see the values. This values. Okay. When B is front, it is called minus, and when A is in front, it is in plus. So 0 means A and B lie in the, when it is 0, it is A and B lie in the straight line. This is 0. And when B lies in front, it is -1. Okay. Now is APTI. APTI is anterior-posterior dysplasia indicator. There are 3 lines. Okay, so there are 3 planes, FH and NPOG. Okay, so this is FH and nasion to go on this angle 1, angle 1. The next angle is FH and palatal plane. Okay, so this is palatal plane and this is FH. So if you just draw palatal plane, so this is the second angle. Something is wrong on that pen. I'm really sorry for that. And the third angle is AB and POG. Okay, so NPOG and a line A and B. This angle. So these are 3 angles that you need to see. And these 3 angles, what is the value? So it is usually 60 degrees. The palatal plane wala is equal to 10 degrees usually. Okay, and this is 9 degrees. So the total value is 62 degrees. So the total value is averagely 81.4 degrees. Okay. This has been asked in exam, so you need to remember it. Now, in which cases it is going to increase? It is going to increase in class 3 and it is going to decrease in class 2. Okay. Now V2. Now we are going to see a few other things. First, this is a which rotator? This is a forward, sorry, this is a backward rotation. And this is a forward rotation. We're going to see a few angles. First is mandibular plane angle. Mandibular plane angle. Okay. Now, this is so irritating. Mandibular plane angle. How do we see this? We draw a mandibular plane and we take a reference line. Usually, let's take SN. Okay. Now, when the mandibular plane angle increases, what will it be? I want you to answer me because this is more of a clinical question. When the mandibular plane angle increases, the angle between SN and the mandibular plane increases. So it is going to be a backward rotator. Okay. So it was going, when the mandibular plane angle increases, it is a hyperdivergent growth pattern. Hyperdivergent. Okay. When it decreases, it is hypo. Okay. Next question which is usually asked is Biot sum. What is Biot sum? Biot sum is a sum of 3 angles. It is also called sum of posterior angles. Now, what all angles do we see? First, you take SN and NA, articulate. You take points. I'll just mention the points. So, points is S, N, articulate, AR, articulate, N, AR, and gonion, and this is mentor. So 1, 2, 3. These 3 angles. So these 3 angles are taken in Biot sum, sum of posterior angles. The value is usually 396 plus minus 4 degrees. Okay. So what if the Biot sum increases? Biot sum will increase when these angles are further like this. So this is a hyperdivergent growth pattern. This sum is going to decrease in hypodivergent growth pattern. It increases in hyperdivergent and it decreases in hypodivergent. Okay, Biot sum. ऐसे ही the gonial angle. The gonial angle decreases in hypodivergent. It increases in hyperdivergent and decreases in hypodivergent. Then is the last, the very important angle is, it's not angle, it is a Zarabach ratio. What is Zarabach's ratio? What is Zarabach's ratio? It is the ratio between the posterior by anterior picture height. Okay. The ratio is usually more than 65 degrees. Sorry, the ratio is usually 65 degrees. If it is more than 65 degrees, and what if it is less? If it is more than 65, it means posterior rotation is happening. Sorry, posterior growth is happening. So what if it is more than 65 degrees? So if the ratio is more, then the patient is forward rotator or backward rotator. Anyone. If Zarabach ratio is more, it means the posterior height is more. So it is going to be a hypodivergent case. Yeah, forward rotator, a hypodivergent case, and if it is decreased, it's a hyperdivergent case. Okay. Anterior and posterior are the facial heights. Okay, sorry. Facial heights. Posterior facial height and anterior facial height. So anterior facial height S to gonion and ANS to mental. So this is posterior facial height and anterior facial height. Okay. I think we have 2 minutes. Zarapak ratio is a ratio between the anterior and posterior facial height. Sorry, posterior and anterior facial height. Okay, so posterior facial height is measured from sella to gonion, and the anterior facial height is measured from nasion to menton. Okay. Now, if the normal is 62 to 65 degrees, when it increases, it means the posterior facial height has increased. So it increases in the hypodivergent cases, and when it decreases means the posterior facial height is less. So it decreases in hypodivergent cases. Okay. Yeah, the value. No. The value is not in degrees. Sorry. The value is in 60 to 65% into 100. Thank you, Dr. Sona. The value is in percentage, 60 to 65%. The posterior facial height is measured by sella to gonion, nasion to menton. Okay. This concludes the cephalometric analysis. Now we are going to discuss about the hand rest radiograph. Now, what are the things of concern? Hand rest radiograph, there is an index called Fishman index. Fishman index is especially important. I would just tell you, okay, can anybody tell me where is adductor sesamoid in this radiograph? Anyone? Can you see adductor sesamoid? Where do you find it? Does anyone know? I'm giving it. Thumb. So this is basically adductor sesamoid. Can you see this little bone? This is adductor sesamoid. Okay. So when this is not visible in a radiograph, means that it is present, but it has not been mineralized. This is why it is not visible. It is absent, matlab it is not visible in the radiograph. Absent doesn't mean that it is not present in the body. It is present. So one more thing that you need to understand is, this is a long bone. Okay, this is a bone, and this is the head of the bone. Iske upar there is a cartilage that grows. So this cartilage has 3 stages. Okay, this is called diaphysis, and the upper cartilage is called epiphysis. So this epiphysis and diaphysis have 3 stages. Epiphysis and diaphysis have 3 stages. First is epiphysis is equal to diaphysis, means if this is a diaphysis and this is an epiphysis, the length of epiphysis is equal to diaphysis. This is stage 1. The next stage is epiphysis caps diaphysis. Okay, so means if this is diaphysis and epiphysis, like it caps the diaphysis like this. Okay, capping. And the third stage is epiphysis fuses with the diaphysis, which has been happened in this bone. Okay, this is diaphysis and the epiphysis has fused with it. So these are the three stages of epiphysis and diaphysis, and this is what is taken care into the Fishman's index. So I'll just write the index and I would want you to learn this. The Fishman index ka stages are right. So first is PP3, MP3, MP5. Then is adductor sesamoid. Then is DP3, MP3 and MP5. Then is DP3, PP3 and MP3, all threes. Okay, and last one is the radius. Now what happens in all these stages is, in first three, epiphysis is equal to diaphysis. In the next three, epiphysis caps diaphysis. And in the last three, epiphysis fuses with the diaphysis. Now, what is this MP3, PP3 and all? Okay, so PP3 is proximal phalanx ka third bone. Okay, DP3 is middle phalanx ka third bone. So this is proximal phalanx ka third bone. So 1, 2, 3. This one. Okay. Then MP3, middle phalanx ka third bone. 1, 2, 3. This one. Then MP5, middle phalanx ka fifth bone. 1, 2, 3. Which is the fifth bone. 1, 2, 3, 4. Actually, this is like we consider it as 1, 1, 2, 3, 4, 5. I'm so sorry. We'll go back. Yeah. Come back again. So first is PP3. This is the third one. Sorry, we count from here. Okay. First is this. MP3 is this. MP5 is this. So PP3, MP3, MP5. DP3 is distal phalanx ka. This is bottom. Okay, I'm sorry. I'll come again. Let's start. What is PP3? PP3 is proximal phalanx of third finger. Okay, so 1 is this, 2, 3, 4, 5. So there are three phalanx: proximal, middle, and distal. Proximal, middle, and distal. So proximal phalanx of third finger. So this third finger ka proximal, this one. This is PP3. Proximal phalanx of third finger. That is MP3. Middle phalanx of third finger. This is MP3. Then is middle phalanx of fifth finger. Fifth finger ka middle phalanx. 3. Then is adductor sesamoid. Then is distal phalanx ka third finger. Sorry, third finger ka distal phalanx. Third finger ka distal phalanx. Then is middle phalanx of third finger. These two done. Then DP3 is distal phalanx of third, done. Proximal phalanx of third, middle phalanx of third. Now question, and then is the radius. So this is the radius. Now question is asked, how many sides are there? So 1, 2, 3, 4, 5, and 6. So there are 6 sides. Okay. So the question is asked, how many sides? 6 sides. Then the question is asked, this adductor sesamoid tells you the growth, tells you the pubertal growth spurt. So whenever it is ossified, it is there in the pubertal growth spurt. Okay. So this is what you need to remember about adductor sesamoid. You need to remember the stages like this. So PP3, MP3, MP5, PP3, MP3, MP5, and TP3, PP3, MP3. Like this. You try to remember it. It will be easier for you. And how many sides? So you count from the thumb onwards, 1, 2, 3, 4, 5 are the fingers, proximal, middle, and distal phalanx of the fingers. So this is how you have to remember the Fishman index. It has been asked in exam. This is why I thought to explain it. Okay, this we'll discuss tomorrow because I'll not be able to discuss it in 6 minutes. So I would ask anyone if you have any doubts from whatever I've explained today. See, somebody has asked me about McNamara analysis. See, McNamara analysis is like, it is not that important. There are just a few things that you need to remember about McNamara analysis. It is the planes that have been the important planes in McNamara analysis. I'll not be able to cover the whole things, but the planes is Bayesian plane in McNamara analysis and anatomic effects. Okay, let's discuss the questions, because without questions there will be without questions. Let's discuss the questions, go back, read again, and then you can come back to me. So A and B angle of 2 degrees indicates what? Yeah, so A and B 2 is the normal relationship. Open bite on a cephalogram shows that MP is mandibular plane angle. MP is mandibular plane angle. So mandibular plane angle with reference to SN you can take. Okay, so open bite will be shown as an increased MP angle. Very good. Next, SNA describes ratio of what? SNA means SN and A point. Okay, so SN is on the cranial base, and A point is on maxilla. So what it describes? It describes the relationship of maxilla with the cranial base. Very good. Next, the deepest point between ANS and superior prostheum. So the deepest point between ANS and superior prostheum is point A. Now point A is called subspinal. Why? Because it occurs below the ANS. Okay, subspinal. Next, which of the following cannot be assessed by a cephalogram? Decrease anterior facial height, you can assess. Increase posterior height, you can assess. Vertical facial asymmetry, you can assess because it is vertically placed. What you cannot assess? Mandibular lateral asymmetry. Now, why you cannot assess? If there is a lateral symmetry, what will happen? There will be two border of mandibles, like this and like this. So, but you will not be able to judge how much asymmetry is there. Okay. Next, on a cephalogram, if FMA angle is 25 degrees. So this was like that, right? Now this angle is 25 degrees. So this is a average base. Now in patients with class 2 division 1, which of the following features would be present? What happens in class 2 division 1? The mandibular incisor angles mandibular incisors are proclined, and the A and B will be more because it is class 2. So what will happen? Why am I saying A and B of -9 will be in class 3 patients. In class 2 division 1, A and B will be more, that is 8 degrees. FMA more than 35 would be in hyperdiverging growth pattern. Okay. Next, difference between the size of the cranium and cephalogram. So you need to remember this. There is always a 5% enlargement. This is nothing that I can help you with. There is a 5% enlargement, not reduction. There is a 5% enlargement. Interincisal angle between deciduous incisors is. Now, deciduous incisors are straight in the bone. They are not proclined. So we have read this. So the interincisal angle is normally 120. So it will be more than that. which is 150. Next. So I have given this question here because this question was once asked, and you need to remember there are two planes which are mentioned in McNamara, which is FH and bayesian plane. You need to remember this. And if, see, there is no time to discuss McNamara, and it is like too much for you to remember. Next, this is also a question which was asked in exam, and you have to remember this as well. The answer is C. So this is one of the important questions. Angle which does not change with orthodontic treatment. Okay, I did not tell you the name of the angles in Bioxum. So Bioxum कैसे था? S N articulate, conion, and mentor. Okay, so this angle is called saddle angle. This angle is called articular angle, and this is called conion. Okay, so saddle angle is in the base of the skull. So this angle you cannot change with orthodontic movement. This is not related to teeth movement. This is related to the orientation of skull with the mandible. Okay. Next, which of the following is used to determine growth pattern of an individual? Now, what are the growth patterns? It is hyperdivergent or hypodivergent. So the answer is mandible. किसी book में ना clavicle का cervical spine दिया हुआ है, so it is not the correct answer. Now, a reliable indicator of pivotal growth spot on hand wrist radiograph is ossification of adductor sesamoid. This we have seen. And उसके अलावा कौन सा होता है? It is MP3. Next, absence of sesamoid bone in a girl of age about normal age of puberty is said to have. अगर absence है sesamoid bone का, okay. So this is not really the absence, it is absence of sesamoid bone on radiograph. It does not mean that it is not present in the body, it just means that it is not shown in the radiograph. So the answer is the delay in reaching puberty. In assessment of skeletal age, see cervical vertebrae we'll discuss tomorrow. So we will discuss it tomorrow. So Ishita, that answer is wrong. We have overshot the time. See, the growth pattern is hypodivergent or hyperdivergent. Okay, the growth stage of an individual, growth stage is determined by cervical spine. Okay, so we are going to discuss that tomorrow, the first thing, and then we will discuss the treatment planning. Okay, do you have any questions from today's lecture? See, a few things you will have to read. I cannot take up all the things in this 2 hours. Dr. Ishita, what was your question, Dr. Ishita? Could you please tell me, or you have posted on with appraisal? You just see it with appraisal. Yeah, so you take 2 points. See, with this, you take occlusal plane and you drop point A up perpendicular to the point plane and perpendicular to the B. So these 2 lines lie in the same line in females. So the degree is 0 degrees, and in males, BO point can come a bit forward ahead, which is minus 1 degrees in, minus 1 mm in males. What is a high angle case? Hyperdivergent is called high angle. Hypodivergent is called low angle case. 6 sites in Fishman index. So I'll write the Fishman index here, and then you can judge कि how many sides are there. So PP3, MP3, MP5, DP3, MP3, MP5, DP3, PP3, MP3. This is something like that. Here is adductor sesamoid and here is radius. So let's see what all. See 1, 2, 3, 4, 5. This is the digits. PP3 is proximal phalanx. This is proximal phalanx. This is middle phalanx and this is distal phalanx. Proximal phalanx of third finger is this bone. Then is middle phalanx of third finger. Then is middle phalanx of fifth finger. Then is adductor sesamoid. Then is distal phalanx of third finger. Then is middle phalanx of third finger. Then is middle phalanx of fifth finger. Then is distal phalanx of third finger. Then is proximal phalanx of third finger. Then is middle phalanx of third finger. So how many? And last is radius. So how many bones? 1, 2, 3, 4, 5, and 6. So there are 6 sides. Okay, Dr. Samson, tab E7. Okay, I think today's lecture has been very productive. I want you all to go back and read Cephalometrics, and tomorrow we will color coding. What is color coding? Okay, what happens is when we take radiographs in a lot of duration, so we have to color code it. We draw it differently. So when the patient starts, we make it in black. When the patient, this is at the start, pre-treatment. When it is in the midway, we draw it in blue. At the end of the treatment, we draw it in red.